Can everybody hear me?
Can everybody hear Justin?
Yes.
Yes.
Hello, good afternoon, everybody. My name is Justin and I'm a recent graduate studying chemical. Today, I'll be presenting quantitative assessment of tissue stiffness using transfer learning of breast cancer pathogen. Our research advisor for the study is Dr. Max Dennis.
Now we cannot hear the presenter.
Oh, hello. Can you hear me closer now? Can you hear me now?
Yeah, a little bit better.
Yeah, I realized. So, okay. So this is the outline that we'll be presenting throughout the presentation today. So for some background, cancer disease is where some of the body's cells grow in an erratic manner and spread to other parts of the body. And according to the World Health Organization, as of 2020, breast cancer is the most common type of cancer. It is the leading cause of cancer-related deaths among females, and approximately 1 in 8 females will be diagnosed with invasive breast cancer in their lifetime, and 1 in 39 females will die from breast cancer. Therefore, early detection of breast cancer is the first stage in diagnosing a patient to decrease their chances of mortality. On the table to the right, made by American Cancer Society in 2019, we can see the probabilities of women being diagnosed with invasive breast cancer for different age groups, and their probability of dying from breast cancer. There are 3 levels of assessment of breast cancer screening. The first is palpation, which is an exam done by touch. This exam can be done by a doctor or by oneself. If the breast is found to be easy to deform, the tissue can be considered normal. However, if it is hard to deform, the tissue may be abnormal. If the tissue is found to be abnormal, clinical imaging by a medical professional is advised. Mammography is used in conjunction with ultrasound to determine if abnormal tissue is benign or malignant. If the tissue is found to be malignant, the next step, the final assessment, is pathology, in which a biopsy is done to confirm the presence of cancerous cells. Our motivation behind this study is that 80% of all breast biopsies, based on the positive finding of mammogram results, are negative for cancer, according to the Breast Cancer Surveillance Consortium. Therefore, what are the harms of false positive mammogram results? They are unnecessary follow-up tests and biopsies, unnecessary costs, and anxiety and psychological distress. Paradigm shift is to reduce the number of unnecessary biopsies. This is done by increasing the ultrasound specificity in determining benign and malignant breast masses using ultrasound-based tissue stiffness imaging, also known as ultrasound elastography. As mentioned before, ultrasound elastography is an imaging technique which provides a 2D reconstruction of the relative local strains in the tissue, also known as elastogram. Referring to the image on the right, normal stress sigma is applied to a tissue to the region L. Normal strain epsilon is measured from the ultrasound tract displacement, delta L of the tissue. And by using Hooke's law, local strain is calculated by delta L over L, which provides a qualitative measure proportional to the tissue Young's modulus, represented by E. So our problem statement is that ultrasound elastography is a qualitative measure of tissue stiffness. Typically, an operator exerts manual compression for normal stress to be applied to tissue. The applied normal stress is dependent on the operator. Slide changed.
Oh, I'm sorry.
So as mentioned before, typically an operator exerts manual compression for the normal stress to be applied to the tissue. And the applied normal stress is dependent on the operator. So our first objective of research question is to minimize the operator dependence using generated tissue displacement. This can be done by internal physiological motion, such as cardiac motion, or an external shaker, such as a loudspeaker. Our next objective is the quantitative tissue stiffness mapping of ultrasound elastography. For this, we use elastograms from a calibrated phantom to train existing deep learning algorithms. We then train and validate existing deep learning algorithms with a small data set. For our methodology of the calibrated phantom, a total of 80 elastograms are obtained for training and validation. The Clarios L7 ultrasound probe was used on the CIRS 049 calibrated phantom. A mini shaker was used to generate tissue displacement at 100 hertz sinusoid. The color code for elastograms are red for soft tissue and blue for hard tissue. The image in the bottom left is the setup of the materials. Beside it is an example of an elastogram. And the table on the top right shows the types of inclusions within the calibrated phantom, their diameter in millimeters, and their Young's modulus in kilopascals. The image on the bottom right shows the elastogram of some of the inclusions within the calibrated phantom. For the methodology of the uncalibrated phantom, a total of 12 elastograms were obtained for testing the new net transfer linear model. The Clarios L7 ultrasound probe was used on the CIRS 059 uncalibrated phantom. The Young's modulus for the inclusions in the uncalibrated phantom are 2 times higher than that of the backplate. The diameter of the inclusions are 8 millimeters, which is similar to that of the type 3 10 millimeters of the calibrated phantom. The mini shaker was then used to generate tissue displacement again at 100 hertz sinusoid. So the image on the bottom left shows the uncalibrated phantom. The top right image shows the brightness mode or B mode image of the inclusion within the phantom, and the image on the bottom right is an elastogram of the inclusion. And for transfer learning, we use a deep learning algorithm. We use a convolutional neural network architecture known as AlexNet. It received the highest classification accuracy with a test error rate of 15.3% at the ImageNet large-scale visual recognition challenge. The ImageNet dataset contains a large annotated natural images in the bottom left diagram. So the ImageNet dataset So the ImageNet dataset contains large annotated natural images. In the diagram in the bottom left, the images from the dataset are inserted into the AlexNet to be classified. NewNet, which is our transfer learning model, we take the pre-trained network of AlexNet as the starting point to learn a new task. In our case, NewNet is trained on the calibrated elastogram images, and we then replace the last layers of AlexNet and reduce the number of classes from 1,000 to 8. So in the diagram in the bottom right, we can see that the FC1000 layer has been replaced by FC8, showing the reduction of classes. And from the results of training and validation in the transfer learning implementation, the software that we used was MATLAB, and 70% of the images that we obtained were used for training, and 30% was used for validation. The training images were resized for data augmentation, and this was done by randomly clipping and translating the training images. The learning rate that we used was 0.001, and we used 60 peaks. And the confusion matrix on the right shows that over 88% of our validation results were correctly classified. The diagonal cells in green corresponds to the observations that were correctly classified, and the bottom row shows the percentages of each class that are correctly and incorrectly classified. The column on the far right shows the percentages of the predicted class that are correctly and incorrectly classified. And from the results of testing of the NewNet transfer learning model, we assume that the CIRS 059 inclusions are equivalent to the type 3 10 millimeter inclusions of the calibrated phantom. The elastogram on the top left was classified. The elastogram on the top left was classified as the expected type and size. However, the elastogram to the right of it was only correctly classified by type. but not size. Therefore, looking at all 12 elastograms, our transfer learning model of NewNet was able to classify the inclusions by type with an accuracy of 91%. It has a 33% accuracy of classifying the inclusion by the right size, and a 25% accuracy of classifying the inclusion as the right type and size. So in conclusion, with transfer learning, ultrasound elastography was able to quantitatively differentiate inclusions that were stiffer than that of background tissue. We were able to successfully apply a pre-trained deep learning model on a small data set, and with computer-aided ultrasound elastography, it has the potential of quantitatively differentiating benign and malignant breast masses based on tissue stiffness values. And by applying transfer learning, we were able to quantitatively classify the elastic moduli of inclusions within elastic. So I'd like to thank the National Institute of Health, specifically the National Institute of Aging. I'd like to thank Tasneem for her contribution to the study, and my research advisor, Dr. Maxwell.